Yes. Good morning, everyone. We'd like to welcome and thanking you for joining us today. We have Mr. Nathan Cron. He is about to release the Kraken for us. Enjoy your breakfast. We have free t-shirts out there. Help yourselves. Nathan?
Good morning, ladies and gentlemen. How is everyone? Before I get started, I just want to ask if anyone knows anything about Greek mythology. Okay, good. Then hopefully you'll enjoy your little flashback to your 6th grade social studies class. What's wrong with diagnostic care today? Over the last 3 years, our healthcare delivery system has struggled desperately to adapt to a new reality that, if we are to be honest, we were mostly unprepared for. But why? Well, we might be excused for failing to imagine that a deadly novel virus would suddenly appear and begin rampaging through humanity. I know, setting aside the fact that we were apparently all forewarned by Bill Gates, the real issue is that our methods and systems for delivering care were mostly inflexible, rigid, templatized. It was like trying to fit the proverbial square peg into a round hole. It just won't work. But again, why? Because we had built a system that for decades had been telling folks, if you want care, you come to us. We did so because we thought that the most cost-effective way to provide care is to centralize, to Six Sigma that thing into submission. But we were suddenly faced with a scenario where the very method and system of care delivery we've built became the enemy of our Hippocratic oath, first to do no harm. So I'll ask the question again. What's wrong with diagnostic care today? It's shackled. It's a captive. It's a hostage chained to the rocks. Let me be clear what I mean. Let me explain. And for that, I would like to retell the story of Perseus. Perseus was a demigod, the only son of the god Zeus and a mortal named Danae. Perseus was one of the greatest heroes in Greek mythology. He earned that notoriety by cutting off the head of the famed monster Medusa, the hideous gorgon with snakes for hair, who turned anyone to stone with the misfortune of looking into her eyes, and then for saving the beautiful princess Andromeda with it. Andromeda was a mortal, the daughter of Cepheus and Cassiopeia, king and queen of mortals. Andromeda was so beautiful that her mother claimed her to be more beautiful than the sea nymphs of Poseidon, god of the ocean. This, of course, outraged Poseidon, who then had Andromeda chained to a rock to be eaten by a fearsome sea monster, Cetus, the Kraken. But Perseus killed the Kraken by showing him the head of Medusa, turning it into stone, saving the princess Andromeda from certain death. Who then, of course, took to be his wife, who then bore him at least one daughter and 6 sons, because life is so fair. One of his sons was Electryon, the father of Acclame, whose union with Zeus produced the most complete Greek hero ever, Heracles. This makes Perseus both Heracles' great-grandparent and his half-brother, both a symbolic predecessor and a worthy peer, which I think is the perfect metaphor for the family of diagnostics providers in the marketplace today. We have the immortals. We have the gods. We have a few demigods. And of course, all of us mere mortals. But who in our story is the hero? I am certainly no demigod. I mean, just look at me. Well, whoever our hero is, they will need to free the diagnostic marketplace from its brick and mortar bondholders, its captors, its Poseidon, and his Kraken. because he who holds access to the mortals dictates when, where, what, and how care is delivered. We need a new paradigm in diagnostic care delivery, patient-centered, community-focused. Now, to be clear, there were already moves in this direction, accelerated by the pandemic, like suddenly everyone had the same idea all at once. At-home care, telemedicine, mobile phlebotomy. I have lost count of the number of startup telemed companies and COVID testing labs spun up in the last few years. Geez, the free market really knows the meaning of gold rush, doesn't it? There are certainly plenty of solutions rushing to market. And why not? Who wouldn't like to be able to order a doctor or a nurse on demand, like clicking a few buttons on your Uber app to order a ride? The on-demand economy meets healthcare delivery. While there are a few companies attempting some variation of this concept, the reality is that healthcare delivery is so much more complex than getting a ride home from the bar on a Saturday night, isn't it? Getting a doc on demand or a nurse nightingale at the press of a button is one thing. Why not a proctologist at your fingertips? Yes, the pun intended. Or a pulmonologist in the palm of your hand. But what if Uber tried delivering you the health care you get from all those folks who do the hands-on work of it, like the medical assistant who takes your blood pressure and records the 5 extra pounds you didn't know you gained since the last time you visited the doctor? Or what about the x-ray tech who jokes with you about protecting the family jewels as he places that lead blanket over your groin before zapping radiation at it? Or how about the kid who draws your blood at the lab? All of these are allied healthcare workers who provide you the prerequisite hands-on care you need. They work under the direction of and are supervised by licensed medical practitioners. They are not, of themselves, qualified to or authorized by any regulatory body to provide any of that to anyone without that direct supervision and control. In short, these are sub-licensed personnel. They're not qualified to be self-employed practitioners of anything, let alone of radiology, of clinical pathology, or even phlebotomy. And yet, as noted, there are a few recent entrants to this niche market attempting to do this. The idea, however, is not so new. The whole idea has been tried and failed spectacularly. Have you ever heard of a company called Igbo? No, you probably don't recognize that name, but that's because they don't exist anymore. Well, to be clear, the company had to rebrand, reinvent themselves after only a few years in business. Igbo was formed in 2015. The company sold service connections to laboratories, practitioners, and phlebotomists. They offered phlebotomists who provided blood draws to laboratories and practitioners. But Igbo, like Uber, was a technology company, not a direct service provider. They did not actually perform the service. They only provided which transactions could occur between buyer and seller. Like when you, buyer, purchase a taxi ride from a taxi driver, the seller, through Uber's mobile app. It's the same transaction model that Igbo was using. A laboratory, the buyer, wants to purchase phlebotomy services from a phlebotomist, the seller, and Igbo facilitated that transaction. Seems simple enough, right? But underneath this thin veneer of simplicity is a morass of complexity, desperately masquerading as legal. But what makes this transaction model so dangerous for the delivery of allied healthcare? Before we examine that question, we need to first take a good look at the context in which this attempt at applying the Uber model to the laboratory industry is occurring. Mobile phlebotomy, mobile and on-site specimen collection, processing, and delivery services is the very definition of a niche business. Many healthcare consumers, even practitioners, have never heard of mobile phlebotomy, let alone that there exist companies that actually specialize in offering such services. The industry's own core customer base is mostly unfamiliar with it, and in particular the legalities of engaging in a mobile phlebotomy service. Therefore, consumer and provider education is a critical component of mobile phlebotomy service delivery. And folks, this is why I'm here today. The mobile phlebotomy industry has its roots in the insurance paramedical exam service. The medical and life insurance industry began to boom in the 80s when employers began offering medical and life insurance plans as standard parts of benefits packages. Actuaries at these insurance companies needed to ensure their growing risk exposure was kept in line with their financial capacity, so insurance companies began requiring medical exams of certain new applicants, accruing data sets that enabled them to fine-tune their product offerings and prices. However, the cost of a full medical exam by a licensed practitioner prohibited ever-increasing screening of applicants. So, a shortened version of a medical exam was created, call it a paramedical exam, that could be performed by allied healthcare personnel instead of licensed practitioners. So today, many life insurance and medical insurance screening examinations are conducted by phlebotomists who are simply collecting basic physical data through a few blood samples and other basic biomeasurements. But a cottage industry of paramedical exam services developed to support the insurance industry's growing practice of screening potential customers. Demand and competition grew in the new paramedical exam business, became acute. The new industry was challenged by price pressure and demands to scale nationally, the same as the mobile phlebotomy industry is experiencing now. The larger services began to cobble together networks of contract labor through partnerships with local providers who also struggled to meet the demand at the price points expected. Thus, the job of the contract mobile phlebotomist was born, which facilitated rock-bottom labor cost and the easiest path to national coverage. The insurance industry has waned in the last decade as employers have scaled back benefit packages. The paramedical exam services have failed or consolidated and desperately began seeking other revenue streams besides the insurance industry. At the same time, the diagnostic marketplace has continued to grow thanks to advances in bioscience and technology. But the industry infrastructure required to facilitate this work has been shrinking. In fact, the laboratory testing industry itself has only just finished a decades-long period of consolidation and regulatory maturation. Biotech companies, specifically diagnostic assay developers, wishing to commoditize their testing products, have been hamstrung by a marked lack of partners among established laboratories whose brick-and-mortar infrastructure can be utilized as product delivery channels. In other words, there aren't enough local and regional independent medical testing laboratories left with whom biotech companies can partner to facilitate specimen collection so that they can market the new diagnostic tests they develop directly to prescribers. The remaining large corporate reference laboratories, of course, now view most diagnostic assay developers as acquisition targets or competitors. In addition, there are many smaller specialty diagnostic laboratories who have resisted and survived the industry consolidation phase of the last few decades. These laboratories have survived in large part to owning some proprietary testing method or product. But because these labs don't have the brick and mortar presence that the big corporate labs do, their growth and access to the market, of course, is largely constrained. So to expand their market reach without the brick and mortar, they began looking to paramedical exam services to do specimen collection and their specialty diagnostics using lab kits. Many of these small labs have gleefully and wantonly engaged these services, as well as a host of mom-and-pop phlebotomy services to perform mobile phlebotomy for them, happy to see their reach expand and revenues climb. For these sectors, partnering with mobile phlebotomy providers makes a lot of sense. But attempting to partner with another lab to leverage their outpatient service centers is a little like letting the fox into the hen house. Furthermore, partnering with other labs to leverage their brick and mortar puts these companies in a very weak position to control the pre-analytical process as well as quality service delivery. Other labs have zero vested interest in their success, and successful ventures exert control over nearly every aspect of their business. Conversely, direct hiring phlebotomists is a highly risky proposition unless you are prepared to provide regular full-time employment to attract the highest quality candidates and all the things that come with owning the workforce. And while many biotech companies seem to be flush with investment dollars, it is exceptionally costly to build out a national brick and mortar presence. Indeed, I have observed some companies try to do just that and fail spectacularly. Because owning this infrastructure requires a diverse revenue stream to support it. A few diagnostics isn't going to cut it. As such, the mobile phlebotomy industry has emerged in support of these and a variety of other constituencies needing fully outsourced specimen collection solutions. Partnering with an independent, fully outsourced specimen collection organization allows testing providers to maintain control while limiting their exposure to the cost burden. And phlebotomy partner becomes a direct extension of the testing provider. And by aggregating demand from a variety of constituencies, the phlebotomy provider is able to achieve the required revenue diversity and depth to support the infrastructure required. So you see, separating specimen collection, processing, and delivery from testing actually enables diagnostics providers to do what they do best: innovate and test. Partnering with an independent specimen collection, processing, and delivery support solution is just plain smart. While mobile phlebotomy has been a common practice for decades, its evolution as an industry of its own is recent and still maturing. Mobile phlebotomy is complex, multifaceted, logistically, technically, and financially challenging. For this and a variety of other reasons, adequate solutions to meet the demand have struggled to scale. The delivery of ancillary healthcare services is highly fragmented in general, but this is acutely evident in the mobile phlebotomy sector. Most of the companies specializing in mobile medical services operate locally and with an urban geographic area where consumers are far more likely to have the income to afford to pay for out-of-pocket or alternative and convenience-based healthcare providers and concierge services. At present, there are no companies that can provide mobile phlebotomy services in every zip code in the country. That would require a veritable army of technicians, and no one has that. It doesn't exist. But there are some claiming to have an extremely broad scale or scope. However, they are being a little disingenuous at best because they're leveraging networks of contract labor technicians. And as I will explain in a moment, this is a wholly inappropriate model for medical diagnostic and research specimen collection. And yet the industry's customers are clamoring for just such solutions. As one potential customer told me, "We need a phlebotomist to be dispatched on demand within 3 to 5 hours to any location anywhere in the country." The customer demand is certainly far ahead of the industry's current capacity. According to market research firm Imogen Research, the mobile phlebotomy industry was a $497.3 million market as of 2020. Since the pandemic, that is now projected to grow to over $700 million in the next 5 years. It is this demand that has fueled the boom in mobile phlebotomy services and enticed some ventures into attempting to apply the on-demand economy model to medical diagnostic specimen collection. And many of the industry's constituents, lacking a full understanding of the structural issues and legalities of mobile phlebotomy, have been all too eager to rush into partnerships with any organization promising a national scale or plug-and-play solutions without much evaluation of the appropriateness or legality of the service model employed. Against this backdrop enters IGBO, proposing to solve the labor supply problem by applying the Uber model, leveraging technology to provide customers on-demand access to a flexible, scalable, low-cost workforce ready and willing to provide the service desired. The new sharing economy meets healthcare delivery. Alison Griswold is a journalist who follows trends in the sharing economy. Interested in IGBO's attempt to apply the Uber model to laboratory specimen collection services, she interviewed IGBO's CEO at the time. In an article on Quartz.com, she wrote, quote, "Like Uber, IGBO is building its business on an independent contractors, which is how it hires phlebotomists. The sales pitch to phlebotomists on IGBO's website went, be your own boss, build your own future." In this article, IGBO's CEO was quoted as saying, quote, "We are a technology company, and we provide deal flow and processes and so forth for the labor force," end quote. Ms. Griswold continued to write, quote, "This is also very much like Uber. which is, as you recall, a technology company, not a taxi company. But what a lot of these companies tend to realize too late is that the Uber model doesn't really fit for them. Sometimes that's because the service they're selling is maybe a little bit more complicated than driving a car. But they can't really train workers who are contractors, as that's typically considered indicative of an employer-employee relationship, end quote. Quote, Igbo will probably realize this too, sooner or later, she wrote. Ms. Gridwall's comments were prescient. Igbo did eventually realize this, failed at the attempt, and had to reinvent themselves. So why is the Uber model so attractive to would-be providers in this space if its legality is questionable? Well, first and foremost, mobile phlebotomy service is a small margin business. The reasoning behind this is twofold. First, there are regional economic variations in price point expectations for certain medical services. The market price point for mobile phlebotomy service nationally across all major markets has an estimated 300% variance. Yet the labor rate variance for phlebotomy technicians is only 67%. This means that in low price point markets, the wage demand leaves very, very little left or no margin at all for labor cost. Second, while the demand for mobile phlebotomy comes from at least 10 distinct customer constituent types, this serves as both a market strength, but a challenge for organizations that offer phlebotomy exclusively. Culling together enough of this low-margin work for these different constituent groups to yield a workable business model is challenging enough. But in addition, there are significant regulatory, administrative, and logistical challenges managing a geographically dispersed workforce to support the varied needs of each of these distinct constituencies. As a result, many organizations that offer mobile phlebotomy usually just specialize in offering support to one or two customer types in just one or two metro markets. As such, they struggle to maintain consistent profitability, which affects their ability to expand into new markets. And the on-demand economy model is perfectly adapted to mitigate these specific market challenges. But is it best applied to the laboratory industry? As a prerequisite to understanding why it is important to consider the labor model as a critical factor in evaluating a mobile phlebotomy partner, it is necessary to review some of the key turning points that have steered the course of the commercial lab industry's development. In 1967, the U.S. enacted the Clinical Laboratory Improvement Act of 1967. CLIA 67 was the first set of regulations on the licensing of clinical laboratories. By the mid-'80s, however, the relevance of CLIA 67 to a vastly changed procedural and technological landscape began to be questioned. In response to public outcry, several deaths attributed to false negative pap smear readings, and a growing awareness among practitioners, regulators, and the general public that there was a high variability in laboratory testing, Congress had held hearings to investigate. The congressional hearings revealed serious deficiencies in quality among laboratories. The Department of Health and Human Services commissioned a study to assess the effectiveness of federal regulations. The analysis found that many federal regulations were technically obsolete and operationally and functionally ineffective. These ineffective regulations had resulted in a growing variability in laboratory testing practices and pervasive incompetence in their performance that had, in some cases, caused harm and even death. So on August 5th, 1988, a new set of regulations were proposed by the agency we all know now as CMS. This ultimately led to the proposal becoming law on October 31st, 1988, as the Clinical Laboratory Improvement Amendments of 1988, or CLIA 88. Prior to 1988, less than 10% of all clinical laboratories were required to meet quality standards. Approximately 12,000 hospitals and independent laboratories were regulated under CLIA 67. Currently, under CLIA 88, there are more than 150,000 clinical laboratories, including physician office laboratories, that are regulated. In the years since its implementation, studies have demonstrated that laboratories meeting these minimum personnel and quality requirements perform better than those that do not. The CLIA 88 law is now a bedrock standard providing assurance to the public that laboratory testing is safe and accurate. But even after CLIA passed and was fully implemented, phlebotomy as a procedure has remained relatively unregulated. Because for many decades prior, it was mostly performed by doctors and nurses until the development and growth of the commercial laboratory industry. Phlebotomy then started to become the purview of the commercial laboratory employer, who needed low-cost labor to perform high-volume specimen collection. These specimen collectors were mostly given on-the-job training. It wasn't until 1998, 10 years after CLIA 88 passed, when a phlebotomist in California was caught reusing butterfly needles, that regulators in California enacted training and certification requirements for phlebotomists in that state. Yes, people sometimes do bad things when they don't have adequate training and when they know no one is watching, even healthcare providers. So curricula and training programs were developed nearly overnight and fueled a small boom in allied healthcare career training schools offering phlebotomy training. Soon after, allied healthcare certifying organizations like ASCP began adding phlebotomy certification to their offerings. Large corporate healthcare employers then began requiring their phlebotomists to become certified by a certifying agency. Over the last several decades, the laboratory industry has become more regulated. The number of local and regional clinical laboratories has declined through attrition and consolidation, and the labor pool used in laboratory sciences has changed dramatically in scope of practice and specialty, and has shrunk as training requirements and certification requirements were imposed by regulations, most recently as it relates to phlebotomy. So what are the current regulations regarding mobile phlebotomy? Did IGBO's use of contract phlebotomists comply with these regulations? Can a laboratory even outsource phlebotomy? It is CLIA standards and a host of other state regulations that provide the answers. First, let's establish that the phlebotomist need not be directly employed by the laboratory. The California Department of Health Field Services guidance on interpretation of California's regulations state that the phlebotomist may work outside of the laboratory and that the W-2 need not originate from the lab. Not that the phlebotomist can be an independent contractor, just that they don't have to be an employee of the lab directly. Furthermore, CLIA regulations allow labs to outsource labor. However, all of the relevant regulations state explicitly that regardless whether the lab directly employs that labor or outsources it to another entity who employs the labor, the entity must have the same oversight and compliance structures as prescribed by law. There is simply no other organizational structure under which a phlebotomist can perform medical diagnostic or research specimen collection. There are a lot of reasons for this, but basically it boils down to the fact that the lab, the organization with the CLIA license under which the results are reported, is ultimately held responsible for the outcome, regardless of who employs the phlebotomist. It is the lab who accepted the specimen for testing. By virtue of accepting that specimen for testing, they are in essence vouching that that specimen has integrity, that it was properly collected, labeled, processed, and handled. The relevant section in CLIA states, if the laboratory director reapportions performance of his or her responsibilities, he or she remains responsible for ensuring that all duties are properly performed. So while it is permissible for the lab director to reapportion or outsource some of the laboratory's duties, it is ultimately still responsible for ensuring the delegated entity or individuals perform as prescribed by law. Further emphasizing this point is section 493.1407C, which states, quote, the laboratory director must be accessible to the laboratory, meaning all personnel involved in the testing process, to provide on-site telephonic and electronic consultation as needed, end quote. This requirement even extends to the laboratory's own clients. To put an even finer point on this matter, in the State Operating Manual Appendix C, issued to states to provide more specific interpretive guidance on the implementation of the regulation, CMS states in section D6004, quote, the requirement that a laboratory must be under the direction of a qualified person is not automatically met simply because the director meets the education experience requirements. It must be demonstrated that the individual is in fact providing effective direction over the operation of the laboratory. In determining whether the director responsibilities are met, consider deficiencies found in facility administration, general laboratory systems, pre-analytic systems, analytic systems, post-analytic systems, and proficiency testing, end quote. In fact, the meaning and intent of some of these regulations have been adjudicated through administrative hearings. In 1999, Oakland Medical Group had its CLIA license revoked, in part for failure to provide the requisite oversight and direction of laboratory personnel for laboratory processes on specimens it tested. In its appeal, Oakland Medical Group attempted to argue it was not a material breach of the regulation because the CLIA regulations referred to the requirement to control employees of the laboratory, and the personnel in question was a contractor. The administrative law judge wasn't buying it and ruled that the employment status of individuals authorized by the laboratory is immaterial, that the relevant regulation specifically provides that delegation of the duties and responsibilities of the laboratory does not relieve the laboratory of the responsibility for their proper performance. The regulations were clearly written with the assumption and implication that the pre-analytical phase would be performed by trained personnel under the laboratory's control or outsourced under an architecture designed to ensure the personnel are competent to perform the procedures outlined by the laboratory. And while phlebotomists can now be certified, certification is not a medical license, and certification is certainly not a substitute for proper training, oversight, and direction. But there are, as yet, no national standards for phlebotomists. So it is wholly inappropriate to rely on certification as evidence of a phlebotomist's capacity to be self-governing, autonomous, as if they were licensed practitioners like nurses and doctors. Fundamentally, the regulations relevant to phlebotomy are implicit in all of the regulations related to the laboratory's responsibility to have, monitor, maintain specific personnel, procedures, and systems to ensure the integrity of the process, from specimen collection to results reporting. If the lab outsources the pre-analytical process, it also outsources the compliance structure required by CLIA of the pre-analytical system. The bottom line is this: although CLIA amendments don't prohibit the use of contract phlebotomists in explicit terms, they do prohibit the use of contract phlebotomists by virtue of the type and extent of oversight and control required to be compliant with the law. In short, CLIA oversight requirements cannot be fulfilled through a contract relationship with a phlebotomist, at least not according to the IRS definition of a contractor. Let's briefly review who the IRS considers a contractor. As taken directly from the IRS website, quote, "The general rule is that an individual is an independent contractor if the payer has the right to control or direct only the result of the work and not what will be done and how it will be done. You are not an independent contractor if you perform services that can be controlled by an employer. This applies even if you were given freedom of action. What matters is that the employer has the legal right to control the details of how the services are performed. The very nature of laboratory work requires control of the details in the performance of the work. Furthermore, laboratories often have specimen collection, processing, and handling requirements that are developed as a part of a protocol unique to the lab's performance of certain types of testing. The IRS uses a 20-factor test to determine if labor is classified as an employee or contractor. This is referred to as the common law test. Now, I promise, I won't attempt to read each of these to you in detail, as I'm certain you would end up wishing me chained to a rock and eaten by the Kraken. The laboratory contract phlebotomist relationship fail significant components of all of these IRS tests. To be fully compliant with CLIA and other state laws is plainly incompatible with the very characteristics that make a contractor a contractor. In addition to the potential problems with the IRS, the contract phlebotomist model has a number of other extremely important problems. A contract phlebotomist typically has no controls over the use and handling or retention of legally protected personal health information. And most phlebotomy technicians, frankly, are relatively ignorant of the complexities involved in compliance with HIPAA and the high-tech security laws. OSHA requires an organization engaging in activity where there is potential for exposure to blood-borne pathogens to provide certain work practice controls to ensure worker and public health and safety. there is very high risk of exposure to bloodborne pathogens in laboratory services, especially phlebotomy. The incidence of needle stick injury and bloodborne pathogen exposure is comparatively quite high. However, a contractor model of employment cannot provide any such training, oversight, supervision, and monitoring of adherence to OSHA regulations. If a needle stick occurs to either the patient or the phlebotomist, there is no one to contact, no one taking responsibility, no support for either the phlebotomist or the patient. This is not a work practice. This is a workplace hazard to contract technicians, but this is also a public health and safety risk. The lack of an infection control policy risks the spread of disease when a technician is entering many different homes of individuals who may be infirmed and have weakened immune systems. In addition, OSHA requires that biohazardous waste materials must be disposed of properly through a licensed medical waste disposal company. Those companies typically contract with medical provider organizations and licensed medical personnel, not individual phlebotomists. This presents yet another risk to public health and safety, as it is highly likely that this medical waste is not being disposed of correctly. The Federal Transportation Safety Administration also has regulations governing the handling and transport of any biohazardous or potentially infectious material. A contract phlebotomist has no training or guidance, no supervision or monitoring to ensure compliance with these laws and regulations either. Lastly, the contract phlebotomists are bearing the burden of the financial risk of injury. Because these phlebotomists are contractors, not employees, they have no workers' compensation protections, no financial capacity to absorb the cost of injury. This creates a highly vulnerable and unstable workforce, which is ultimately a serious liability to the industry and counterproductive to clients seeking these services. The Uber model may be able to quickly solve a labor supply problem, but that does not mean it's best applied to all scenarios where such challenges exist. If ever there was a case study demonstrating this fact, it is the use of contract phlebotomists to perform highly regulated, high-risk specimen collection, processing, and delivery services. This is by any measure an acceptable model for the performance of laboratory processes. This is indeed the kind of compliance slippage the CLIA law and its regulations were intended to prevent. The laboratory testing industry tends to focus on control of the testing phase, and Indeed, much of the emphasis of the regulations is centered on controlling the testing. But we would be remiss to forget that a properly controlled pre-analytical process is prerequisite to a valid test result. Consider the following. The greatest number of errors in laboratory testing occur in the pre-analytical phase. And the greatest number of complaints received by CMS and the California Department of Health Laboratory Field Services Division are related to independent mobile phlebotomists performing uncontrolled and unsupervised phlebotomy as contractors. As such, many states have implemented more rigorous regulations governing the use of phlebotomy personnel and now explicitly prohibit phlebotomists from working independently to perform medical diagnostic sample collection. But even where states don't prescribe specific rules for the utilization of phlebotomy labor, CLIA provides the guidance. And as we have just reviewed, a contractor relationship between laboratory and individual phlebotomist does not meet any of the regulatory requirements for this work. Ergo, the model is non-compliant and illegal. But look, even if it were legal, we need to ask ourselves, is this smart? Is this good healthcare? What does the sharing economy have to offer healthcare? A recent study and report by PBS provides some very useful insights into the dynamics at play in the sharing economy model. Over 64% of contractors are contracting on a part-time basis. This finding runs counter to the common assumption that most contractors rely solely on their contracting income. Over 72% of these workers had been contracting for a year or less. Not only are these new contractors inexperienced, but also experience highly variable pay. Imagine that you made $60 one week and $800 the next. Most contractors don't actually make a lot of money. The median income for full-time contractors is below the median personal income for employees. It's much worse for part-time contractors. This is the challenging reality for most independent contractors. So now imagine these are the folks providing you health care. Would you be a little hesitant? Even a little afraid? We have seen too many examples of the consequences of entities and individuals attempting to thwart regulations or push the boundaries of acceptable practices. The Theranos saga is, of course, the most glaring example of this in recent memory. A fake it until you make it tragedy. The point being that the industry's regulators do not take kindly to risky behavior, and rightly so. We are literally dealing with people's lives. This should be a clarion call, a cautionary tale to the industry. Do not be fooled by these attempts at Uberizing healthcare delivery with its promises of high margins and slick user interfaces if the compliance framework is opaque. While I certainly understand that for-profit businesses have a need to maximize revenue and minimize costs, we must recognize that this instinct will always be in conflict with the core tenets of good healthcare, transparency, and best practices. And in the science of laboratory medicine in particular, there is no place for practices that pretend to be good patient care just because it makes for good profits. These laws and regulations were developed to improve patient care and protect public health and safety because people got hurt and died as a direct result of uncontrolled, non-standardized laboratory practices. By the way, IGBO rebranded as a company called WorkPath. But as of today, according to a statement by WorkPath representatives, they are no longer onboarding new clients. What we have observed more recently is an attempt at a hybrid model, an employed model, with an on-demand touch, using a hands-off approach to compliance, oversight, and control. What this looks like is trying to have your cake and eat it too. It's compliance, oversight, and control in name only. It's an attempt at constructing digital babysitters for technicians instead of real person. They're asking us to trust an algorithm to ensure the human did what needed to be done in the manner it had to be done in a complex, variable environment. In short, they are trying to replace the hands-on work of a supervisor with a few lines of code. While this model recognizes that an employment relationship is prerequisite to compliance, it still doesn't acknowledge that the practice of mobile phlebotomy is a unique animal. Having done this work for nearly 25 years, both in the field myself and as a leader in one of the original and oldest organizations in this space, I can tell you with absolute conviction, I can take a phlebotomist that has 15 to 20 years experience in the lab, and when we put them out in the field, they lose their freaking minds. No matter how good they are at the stick, as they say, we have to train technicians to perform those tasks in a complex, variable environment with the same degree of consistency and precision. And that requires people with specific experience and skill sets who have the institutional memory to train and mentor those technicians. I just want to pause here for a moment to bring this point home because it's very important. Here in this room with me today is the living embodiment of this point, Barbara Wren, who is our operations manager, has been a licensed MLT and worked in the lab for more than 20 years. Dr. Eric Mehta, who is actually MD, is her assistant, our associate operations manager. She could teach a master class in directing and supervising mobile phlebotomists because she's done it herself. She's been supervising them for more than a decade. You cannot replace that with an algorithm. I would not dream of replacing her with a computer-generated substitute. The impact to our quality control and patient care outcomes would be disastrous. This effort at doing just that is simply trying to create a digital replica of the human oversight and control architecture prescribed in current law. The fact is, even that human oversight prescription for use of phlebotomy labor in a controlled setting, the lab or the patient service center, is only the bare minimum needed to ensure consistently successful performance of those processes in a field context. At best, this effort represents a gross lack of understanding about the application of mobile phlebotomy as a field service. At worst, it is a shockingly arrogant belief that the required compliance, oversight, and control can be easily performed by a supermarket self-checkout machine. My question is, who are the subjects in that experiment? And did they give their full consent? In the meantime, Quest and LabCorp have recently established a partnership with a new independent phlebotomy company, of course, motivated by the pandemic gold rush to virtual care and healthcare commercialization, because even Poseidon and his Kraken, even Poseidon knows his Kraken is eventually doomed to fail. Their brick and mortar won't be the beast it once was for very much longer. However, this company seems to be using this hybrid on-demand economy model, employment on demand. Their technicians get paid if they have an appointment. The company is also still just in startup phase, using your typical fake it until you make it approach and losing a ton of money in the process. The company is heavily tech-focused and more than a bit light on the supervisory personnel. They are clearly investing heavily in the digital infrastructure required to push a healthcare commercialization agenda, but at the expense of the human capital needed to successfully ensure the hands-on compliance, oversight, and controls required by law. We tested this out recently and found that the technician is paid a full 8-hour day, even if they only have one appointment that day, but don't get paid on days when they have no assignments to be given. In other words, the company is still just trying to generate the big momentum. It is my experienced view that this company will soon find out the business of mobile phlebotomy is vastly more complicated and challenging on all levels than you imagine it to be. And piggybacking on the big boys is a neat trick, but certainly does not meet the needs of the broader market for mobile phlebotomy services, is still highly risky to patients, and will likely produce a significant amount of workforce churn and poor patient care outcomes. So what is the solution then? What would a practical and legal framework for mobile phlebotomy look like? The answer is really quite simple, straightforward. At minimum, anything a lab has to do to manage the pre-analytical phase, a mobile phlebotomy company has to do as well. In separate legal opinions written on the topic, attorneys have outlined the specific applications of law and succinctly summarized the regulatory obligations a mobile phlebotomy company bears. First, the company must have oversight by a laboratory director. Phlebotomists must have ongoing supervision, active supervision by someone qualified to be a CLIA licensed laboratory director, or a designee of the laboratory director who has the delegated authority to carry out the lab director's oversight obligations. These provisions require the laboratory director or designee to ensure that the company's technicians have the necessary certification, training, education, and are competent to perform the entire pre-analytical workflow by conducting a full and comprehensive skills and competency assessment at hire and at least annually thereafter. A review of the work of each technician must also be performed on a monthly basis. The director or designee must be available to where the technician is working to provide a consultation, either in person, via telephone, or via electronic means within minutes, not hours. The company has an obligation under law to provide written policies and procedures for monitoring, assessing, and correcting identified problems in the pre-analytic system. To achieve legal and ethical standards, the company must conduct its own assessment of the effectiveness of policies and procedures continuously and systematically. The company must have an active and robust compliance monitoring and quality assurance program, which necessarily includes the human capital in its adequate performance to fully demonstrate that it is proficient at taking on the delegated authority. Furthermore, related to its own compliance, the company must assist its contracting laboratories to remain in compliance themselves and have open lines of communication in which they facilitate the transfer of information vital for that compliance. Because recall, these are only the minimum requirements for the performance of mobile phlebotomy to be legal and compliant with the law. To actually be good at it, the company needs to do much more than that. The company should also invest in its technicians' professional continuing education and should have a training program specific to the performance of mobile phlebotomy, including patient interaction and communication skills training. Organizations looking to engage with mobile phlebotomy providers ought to look for companies that have established themselves in this niche market with a fierce dedication to quality, dependable services built on the best practices of the more experienced, broader laboratory industry. Look for an organization that has a wide range of customer constituencies and a stable contractual service clientele, including large institutional clients? Does the company have a centralized or decentralized control model? How much control over the workflows is distributed to the technicians versus performed by a specialized operations team coordinating and managing those workflows? I firmly believe the industry needs a new model for the delivery of diagnostic care, but we must do so carefully, with deliberation and attention to the best practices that first and foremost result in reliable and effective patient-centered care. The laboratory industry needs to partner with exceptional providers of in-home and in-office specimen collection support solutions. Demonstrating your commitment to partnerships that emphasize and enhance the delivery of patient-centered care produces goodwill among practitioners and patients in the communities we serve. Indeed, it helps communities develop resilience against an increasingly unpredictable world. You are key players in that, not just in community health, but in building connections with people. And when people are connected, communities are stronger and more resilient. Making deliberate investments in connecting people to the care they need shows your organization to be at the forefront of a customer service culture in healthcare, as well as a leader and innovator in diagnostics. We must be brave, like our hero Perseus. To be free from a system of diagnostic development and care delivery that stifles innovation, limits access to care, and discourages resilient communities, we need a new patient-centered, community-focused care delivery model. Independent phlebotomy and specimen collection can facilitate this transformation by breaking down barriers and overcoming barriers, building community connections, improving patient care outcomes, and ultimately making care more effective and adaptable, and therefore less costly. This paradigm shift has already begun, accelerated by the pandemic, sure, but it's been a long time coming. It started several years ago with structural changes to the healthcare delivery system incentivized by the Affordable Care Act. With the Affordable Care Act came a focus on cost containment, patient care outcomes, and the promotion of the medical home model. And independent medical specimen collection support service providers directly contribute to the fundamental objectives of the ACA and the medical home model in very real, tangible ways. We act as a bridge to the healthcare delivery healthcare system access points that enable the coordination of care within a medical home model system. By removing the structural barriers to access care, we help facilitate important diagnostic care for critical need populations, thereby improving the management of disease, preventing and lowering emergency room utilization, and encouraging appropriate healthcare measures, which lowers healthcare costs and improves patient care outcomes. And as we have seen in the last 3 years, it even saves lives. Even before the pandemic, for many individuals and families, access to healthcare was not easy or convenient. And now, it's even harder. Over the decades I've been doing this work, I've met with many individuals, their families, practitioners, and laboratory professionals, as well as those in the home care and assisted living industry. And one common observation emerges. Accessing even routine, basic diagnostic services can be a logistical, time-consuming, and expensive nightmare. In particular, homebound and mobility-challenged individuals must often rely on family members, friends, or neighbors for transport to a laboratory facility, or bear the burden of paying for private transportation. Even individuals for whom transportation and mobility are not obstacles to healthcare likewise still face significant disincentives and barriers. It is just all too common that these patients simply never go to the laboratory for the testing prescribed by their practitioner. This, more often than not, results in delayed, deferred, and inadequate care because the practitioner never receives the diagnostic data needed to provide the best care possible for their patients. Then a deadly pandemic came, and suddenly our survival was in the hands of frontline healthcare workers like these phlebotomists. Fortunately, mRNA technology helped us avoid what would almost certainly have been a near apocalyptic outcome for our species. Now, mRNA science is being studied for potential cures to other things that plague our world. This and many other monumentally important efforts in medicine, science, and technology have enabled us to imagine what was once unimaginable. Suddenly, it doesn't seem so far-fetched to search for a cure for cancer or cut the global fetal mortality rate in half from 2.6 million annually and save 1 million newborns a year, or eradicate HIV and AIDS. Anything now seems possible. And blood is at the heart of it. To continue moving forward toward this healthier world we imagine, we have to acknowledge that everyone in the healthcare delivery chain is critical. We need to facilitate and support the professional development of our technician labor and reject this fantasizing over engineered versions. We must seek to elevate the work they do from lowly technician, long viewed as a disposable role in healthcare, to that of an indispensable member of the healthcare workforce. They are not mere technicians. They are heroes in health, science, and medicine. And honest, effective, community-based healthcare requires them. They are the face of your organization. They are who your patients build relationships of trust with, not the ones and zeros that try to make a poor substitute. Their role in the lives of your patients is profound. It is critical and should weigh on us with the burden that comes with the responsibility of managing them, but also make us proud to do what we do, to be who we are, a critical link in that chain protecting humanity from disease and death, and making our world a little bit better in the process. And that is what our organization is all about. Ours is a nonprofit, so you can be certain we are people motivated, not profit motivated. We serve a variety of customer constituencies across the healthcare and research spectrum, from managed care organizations like Kaiser Permanente, to biotech companies like Bristol Myers Squibb, doctors and private and group practices, residential care facilities, skilled nursing, assisted living, group homes, laboratories, specialty diagnostic and reference, home care agencies, and of course, thousands of individual patients and their families access our services directly on an ongoing basis. But whoever our customer is, it is obviously all about the patient. They are the reason we do what we do. For decades now, we have been working to bridge this critical gap in our healthcare delivery system. We have never strayed from our vision of service, convenience, and commitment to care. We continue to facilitate diagnostic care by providing practitioners and their patients with a link to medical diagnostic and research testing providers by successfully overcoming obstacles wherever and whenever they exist. We have been making a big difference in people's lives. We have stepped up to reach people who need it most, those unable to help themselves, and family members desperate for help and support, those often lost in a chaotic and complicated healthcare system. We have facilitated advances in bioscience and medicine by supporting critical clinical research in new diagnostics and new therapies. Thanks to the work we do, access to cutting-edge diagnostic care is possible. And we have even forced insurance payers to recognize that what we do is valuable and worth compensating. We have influenced change in healthcare by challenging the status quo and proving there is a better way. We are committed to facilitating a transformation in healthcare delivery from something people dread and avoid to something they seek. So I invite you, join us. Let's work together to create better healthcare for ourselves, for our families, and for our communities. Thank you.